All right, class. This is Chapter 11, Equipment Design for Radiation Protection. Here we have the tube housing, off-focus radiation coming out from the tube, safeguards patient and imaging personnel from leakage radiation. It is lead lined. Leakage radiation is measured at 1 meter away from X-ray source. Dose should not exceed 0.8 milligrays an hour or 100 milliroentgens an hour. So X-ray can leak from the X-ray tube, from the port window. Here's the primary beam. This tube is lead lined. Okay, it can also leak from the collimator as well. Beam restrictors, cones, and cylinders, used a lot before other beam restriction devices created, still used in some examinations such as headwork, vertebral column, and chest. So here we have the cylinders here that kind of cones the beam. You'll see these on C-arms. This is the cone, cylinder cone here, and the flared cone up here. We really don't really see these much anymore, except at older facilities or maybe in the lab. Or as you see here, they're used for head work. So beam restrictors, cones, and cylinders. Where have you seen these cones? Beam restrictors widely used. Because of its set beam restriction parameters, it was replaced by collimators. So we really don't use these much anymore. Beam restrictors, collimator, 2 sets of adjustable shutters, mirrors, and light source. Adjustable, reason it replaced earlier beam restriction devices. So again, cathode, anode, we have our X-ray tube. It goes through the port window. We can have leakage from this area here. We can also have leakage from the collimator box as well. What's important to remember are there are different types of filters. We have aluminum filters here, like usually lead shutters as well. Beam restrictors collimator reduces X-ray beam to area of interest. Actual X-ray beam and localized light beam should not exceed 2% of the SID. So that's a state regulation. What does that mean? At 100 centimeters or 40 SID, light and X-ray beam should not exceed more than 2 centimeters of difference. So again, we have our collimator box here, adjustable lead shutters comes through here. So just like I said earlier, we have some parts that are made from aluminum and then some parts that have lead. Positive beam limitation. PBL adjusts so that the radiation field matches the size of the image receptor. So if you put a 14 by 17 cassette in there, then the light field should be 14 by 17. If you put a 10 by 12 cassette in there, then the light field should only be 10 by 12. This can be turned off with a key. With PBL, we protect patients because our beam will never be larger than the field size. The only time we should really ever turn the key off is for if you're doing tib fib in the table bucky. Filtration removes low energy photons, leaving higher energy photons in our primary beam. 2 types: inherent, found inside the tube; added, outside the tube above collimator. Total filtration of 2.5 millimeters of aluminum or equivalent for units using 70 kVp or above is standard. So here all the X-rays are hitting the filter and only the high energy X-rays are coming out. They call that as hardening the beam. Filtration, stationary, fixed, radiographic equipment. Again, above 70 kVp, total required is 2.5 millimeters of aluminum. From 50 to 70 kVp, only 1.5 millimeters of aluminum is needed. Below 50 kVp, 0.5 millimeters of aluminum. This is important for like mammo, and anything above that is what we pretty much use in X-ray. Mobile diagnostic units, portables, fluoro equipment, C-arms require a minimum of 2.5 millimeters of aluminum equivalent for total permanent filtration. Again, we have our aluminum filters here, and usually we have like lead shutters down over here. Aluminum is most widely selected filter material, removes low energy photons, lightweight, sturdy, and it's inexpensive. Radiation Control and Health and Safety Act of 1968 states a diagnostic X-ray beam must always be filtered. Important concept to remember is the half-value layer. It's used to measure the thickness of the absorber required to decrease beam by 50% of initial value. This is expressed in millimeters of aluminum. So here we have, in order to cut the 70 kVp in half, you need 1.5 millimeters of aluminum. So in order to cut the kVp from 50, we need 1.2 millimeters of aluminum. So we have all the way up to our chest X-ray kVp 120, and we need 3.2 millimeters of aluminum to cut that in half to 60. Compensation filters. Differences in part thickness and what we are imaging can be made uniform in a reduced dose by using a compensating filter. Compensating filters are made of aluminum or lead acrylic. Two common types are wedge and trough. So here we're using like the anode Hill effect with the wedge filters. We know that the lungs are hollow, so we don't need that many x-rays penetrating through this. It'll burn out the image on the image receptor. The area over the abdomen, we don't need any kind of filter, so all of those beams can penetrate through the abdominal, through all the organs, through the spine as well. Exposure, reproducibility, and linearity. Reproducibility consists consistent output of radiation intensity. For any combination of kVp, mass, time, settings, duplication of exposure, variance of 5% is acceptable. So what we're saying here is that in order to get an output of 100, let's say we did any kind of combination of like 20 kVp at 5 mass, or 5 kVp at 20 mass, or 10 kVp at 10 mass. So any kind of combination will give us a consistent output, and the variance of 5% is acceptable. Linearity is consistent output of radiation intensity. At select kVp, mass settings are changed. So linearity is different in that we only change mass. When changing the mass settings, change the combination of time and mass, intensity should stay the same. The variance for here is 10%. So an example of that would be, let's say the mass needs to be 20. So we would change like 5 MA times 4 seconds, or let's reverse that, 4 MA times 5 seconds, or 10 MA at 2 seconds, or 2 MA at 10 seconds. And that variable should only be 10%. Grids made of alternating lead strips and strips of aluminum, plastic, fiber, or wood. Used to clean up low energy photons. An example would be scatter. Improves image quality through better contrast and better visibility of detail. Linear and crosshatch grids in X-ray use increased patient dose. Linear grids are used in fluoroscopy, increased patient dose, image receptor positioning. An example would be grid cutoff. Since part of the grid is absorbing X-rays, we will need more mass to compensate. Higher the grid ratio increases patient dose. Source to skin distance. The source to skin distance you need to know is not source to skin dose. So it's basically the SID from here to the patient, not to the image receptor. It's just from, again, from the source to the skin. When SSD, source to skin distance, is small, the patient's entrance exposure is significantly greater than the exit exposure. It's usually at least 3 times higher. Source to skin distances, by increasing the SSD, the divergence of the X-ray beam over the patient will be decreased even when a grid is not used. The radiographer thereby maintains a more uniform distribution of exposure throughout the patient. The following are important for source to skin distances. Stationary X-ray units, 15 centimeters or 6 inches below collimator. So that's the distance, that's the minimum distance from here to here. Portable X-ray units, 30 centimeters, 12 inches. Portable C-arm units, 30 centimeters, 12 inches. Stationary fluoro, 38 centimeters, 15 inches. So basically all of the stationary are is a little bit longer. In this case, the stationary fluoro is longer. The stationary X-ray unit, the routine room, is only 6 inches. The portables are the same at 12 inches. So digital imaging techniques, a comparison with film, you really had to know your technique. If we use 70 kVp at 1.6 mass, the image is underexposed. Here at 25 mass at 70 kVp, the image is overexposed. You can't really see the soft tissue. So we really, techs before had to know their techniques. Here we have 70 kVp at 6.4 mass, 70 kVp at 12.5 mass. Even though the mass is doubled, both of these images would be acceptable. Whereas digital, the computer software kind of cleans up all of our images. 2.5 mass at 70 kVp gives us the same image as 70 kVp at 80 mass. So in here we can overexpose our image and get the same picture quality as one as low as this one here. Another good thing to look here is this image is comparable from film to the digital one, but we're using like 4 times less mass. So the kVp is still the same at 70, but instead of 12 mass, we're only using 2.5 mass to give us the same type of image. So this is the reason why Texas Children's Memorial Hermann isn't using shielding anymore, because we can get the same type of dose with a fraction of the radiation needed. So that brings us into dose creep. Again, with the advantage of digital, the amount of exposure to the patient has increased. A lot of techs will, when they use that term, when in doubt, burn it out. So if they don't know their techniques, they'll just use high exposure factors, high exposure techniques, and over irradiate the patient. Should not overexpose a patient because the computer will compensate. Very important to learn techniques. Routine practice of overexposing patients to avoid possible repeat radiographic exposure is unethical and unacceptable. For fluoroscopy procedures, the largest patient exposure in X-ray. So regular X-ray, there's not a lot of dose to patients, but fluoro, of course, for upper GIs, small bowel follow-throughs, BEs, a lot of radiation dose for the patient. Same thing with C-arm as well. Image intensification, or II fluoroscopy. Most modern fluoro machines have image intensification. Benefits include increased image brightness, savings of time for the radiologist, and patient dose reduction. So here we have last image hold right here with the flat panel monitors. We can take a picture here, and then we can actually put the image to the right side for reference for later. Here is that image intensifier right here. And basically that saves dose for these reasons: increased image brightness, savings of time for the radiologist, and patient dose reduction. Modern units brightness increases 10,000 times. This has increased radiologist perception of images. Modern fluoro units only need 1.5 to 2 mA for procedures versus older machinery that uses 3 to 5 mA. Things such as pulse fluoroscopy help decrease patient dose and extend life of X-ray tubes. Last image hold uses 2 screens for comparison. For fluoro, it's pretty much all high kVp, low mass. You can get up to like 110 kVp, but the mass will only go up to like 12. Again, this is important to remember the image intensifier. So image intensification fluoroscopy continued. A primary protective barrier of 2 millimeter lead equivalent is required for all fluoroscopy units. The image intensifier assembly or digital detector provides this barrier to direct radiation. Again, x-rays coming through here. You have your glass envelope, kind of like x-ray, focal point here, and anode. Cumulative timer is important on this fluoroscopy units. Audible, it makes a noise at the 5-minute timer. There is a visual light. Intrinsic skin exposure rates maximum is 100 milligray per minute or 10 R a minute at tabletop. So we have a bunch of different focal point sizes here, 30, 25, 20. Image intensifier tube produces a magnified image in 25 centimeter mode, whereas 20 centimeters is more magnified. So the smaller the focal point, the more magnification you get. Magnification causes detail and brightness loss. MA is adjusted to compensate, causing more patient dose. Here we have the mobile C-arms. During procedures, image intensifier, patient distance should be as short as possible. This reduces patient intrinsic dose. So what we're saying here is that this part here needs to be furthest away. The X-ray tube needs to be furthest away from the patient to reduce the entrance skin dose right here. The image intensifier is basically the same as the IR, and that needs to be closest to the patient. Portable fluoroscopic machines, X-ray tube on one end, image intensifier on the other, used in OR mainly. So again, X-ray tube should be down below the patient, and the image intensifier should be above the patient. If you look at the scatter coming from the tube, most of the back scatter is underneath the table, which is where we want it to be. It comes in through the patient, and you have some scatter that leaves the body from the top part. Like in fluoro, the X-ray tube should be positioned under the patient dose for reduction. Scatter radiation is less intense at the top. Over the patient position will cause more exposure to personnel. So if we flip this around the other way, most of that back scatter, if the X-ray tube is above the patient, then most of the exposure will go to the personnel. Safety features in digital fluoroscopy. Most of this, again, should have been covered in Mr. Dawes' class as well as Ms. Francis's. Here we have digital subtraction records corresponding pixels of an image pair. Final image is the difference between the two. So here we have the contrast right here. Here we have our catheter or needle inserting. The contrast is here, and then these are just all of the other veins in the body. So we have the post-contrast image here. The pre-contrast is just of the veins of the body without the contrast. And then we can subtract the image, and we can just see the contrast as shown here. With road mapping, it's the exact same picture. We have the live fluoro. And this is exactly what it would look like without the roadmap. So it's important that we actually can highlight what we need to see without all of the distraction of the other veins. Another good thing about this is we can save the image, so we don't have to keep injecting contrast. If the more contrast we use in the body, it can damage the kidneys. So we can actually kind of hold this static image here and then just kind of thread the catheter. It's where we can just use live fluoro to see the stent or the needle that needs to go in with like another image that's laid on top of it right here. So we can have like a residual image or an overlapped image of the contrast so we can kind of see where this is going. Road mapping is post-contrast subtracted ghost images of inserted wire on static images without distracting underlying tissue. So again, that's just what I said earlier. This would be the distracting underlying tissues with all the other veins. This is the contrast, but instead of injecting contrast for like 20 minutes, we can inject it once for like 5 minutes, or just a couple minutes, and then overlap a ghost image so we can kind of trace to see where the needle should go, or the catheter should go into, or the stent. High-level control interventional procedures. So again, interventional, this has to do with IR. IR procedures such as drains, biopsies, employ the use of high-level control fluoroscopy. So again, lots of radiation in IR and cath lab. Exposure rates are substantially higher when utilizing high-level control interventional fluoro. These rates allow for visualization of structures that may not appear during regular fluoroscopy. High-level control interventional procedures. Patient monitoring and accurate record keeping is important when patients are exposed with high-level control fluoro. Since onset of some skin injuries like erythema and desquamation might not appear for 10 days, the FDA has recommended that a note be placed in the patient's record if skin dose is in the range of 1 to 2 grade tissue. Procedures involving extended fluoro time. So percutaneous transluminal angioplasty, radiofrequency cardiac cath ablation, vascular embolization, stent and filter placement, thrombolytic and fibrolytic procedures, percutaneous transhepatic cholangiography, ERCP, transjugular intrahepatic portosystemic shunts, percutaneous nephrostomies, biliary drainage, and urinary or biliary stone removal. Here's some questions from the textbook. The radiographic beam should be collimated so that which is of the following: slightly larger than the image receptor, no larger than the image receptor, twice as large as the image receptor, 4 times as large as the image receptor. The answer is no larger than the image receptor. Both alignment and length and width dimensions of the radiographic and light beams must correspond to within 1% of SID, 2% of SID, 5% of SID, 10% of SID. 2% of SID is the correct answer. Which of the following aluminum equivalents for total permanent filtration meets the minimum requirement for mobile diagnostic and fluoro equipment? 0.5 mm aluminum, 1 mm aluminum, 2 mm aluminum, or 2.5 mm aluminum? The answer should be 2.5 mm aluminum. When changing one MA station to a neighboring MA station, the most linearity can vary is 5%, 10%, 20%, or 50%. And the answer should be 10%. Strategies to manage dosed patients. So this may help you with those people who need to do your group projects for the general public. So immediate, optimized dose to patient, use proper radiographic techniques, maximize distance between X-ray tube and patient, minimize distance between patient and image receptor, limit use of electronic magnification, control fluoro time, limit use of necessary evaluation of moving structures, employ last image hold functions to review findings, control images, limit acquisition to essential diagnostic and documentation purposes, reduce dose, reduce field size, collimate and minimize field overlap, use pulsed fluoro and low frame rate. So pulsed fluoro is always preferred over just live streaming. Okay, for long-term strategies to manage patient dose includes medical physicists and decisions, machine selection and maintenance, incorporate dose reduction technologies, and dose measurement devices and equipment. So use CR instead of DR. Use DR instead of CR. Establish a facility quality improvement program that includes an appropriate X-ray equipment quality assurance program overseen by a medical physicist, which includes equipment evaluation inspection at appropriate intervals, which is usually annually. Strategies to manage dose to staff. Again, this is great for your group projects if that is your topic. Minimize dose to operators and staff. Keep hands out of the beam. Use movable shields. Maintain awareness of body position relative to the X-ray beam. Horizontal X-ray beam, operator and staff should stand on the side of the image receptor. Vertical X-ray beam, the image receptor should be above the table. Wear adequate protective, well-fitted lead apron. Wear leaded glasses. Improve ergonomics of operations and staff. Train operators and staff in ergonomically good positioning for use of fluoro equipment. Periodically assess their practice. Identify and provide the ergonomically best personnel protective gear for operators and staff. Urge manufacturers to develop ergonomically improved personnel protective gear. Recommended research to improve ergonomics for personal protective gear. This is our last slide. Exposure controlled devices. On-off trigger, dead man switch, emergency shut-off buttons, interlocks for detenting, 5-minute timer on fluoro, remote control fluoroscopy, and AEC, automatic brightness control, ABC, and automatic exposure rate control are all the same things. So these are all ways that we can reduce doses for our patients and ourselves. So making sure that everything is detented. We have a timer that reminds us and the surgeon or the radiologist that we're reaching 5 minutes on the timer. There are remote control fluoro units now, just like in the specials or like in lumbar punctures. There's always a special room like at Memorial Hermann TMC where Ramon works. And that is it for this lecture. Thank you.